Hi, I am Peter Glowicki from Mayo Clinic, Editor-in-Chief of the Journal of Vascular Surgery. I am pleased to share with you the highlights of the very best papers we assigned to the May issue of the JVS. The Editor's Choice article this month is the Guidelines for Hospital Privileges in Vascular Surgery and Endovascular Interventions, authored by Dr. Keith Caligaro and colleagues from the Society for Vascular Surgery. This important and long-awaited document was endorsed by the Association of Program Directors in Vascular Surgery. The guidelines start with current definition of our specialty and states that vascular surgery deals with the diagnosis and management of disorders of the arterial, venous, and lymphatic systems, exclusive of intracardiac and intracranial vessels, but including the thoracic aorta. It also defines 6 areas where a fully trained vascular surgeon must have advanced knowledge and experience. Now, these include the pathophysiology and natural history of vascular disease, clinical management, vascular diagnostic testing and imaging, open vascular surgery, endovascular therapy, and critical care management of the vascular patients. In 2018, there are 3 valid pathways for training and certification in vascular surgery. The traditional 5 and 2 pathways that requires completion of a total of 850 cases and 250 major vascular cases. The integrated pathways, or 0-5, with 500 total cases and 250 major vascular cases as requirements. And finally, the early specialization pathway, the 4 and 2, that requires again 850 total and 250 major vascular cases. Now, current minimum criteria for endovascular and open cases include 20 EVARs, 80 endovascular therapies, 100 diagnostic endovascular procedures, and 10 complex, 45 peripheral, 25 cerebrovascular, and 30 abdominal operations. The IAC guidelines for supervised interpreted studies include 100 peripheral arterial physiologic and 100 duplex scanning, 100 peripheral venous duplex scanning, 100 carotid and 100 transcranial duplex studies, and 75 visceral vascular duplex scanning. Guidelines for new hospital privileges includes completion of the ACME-approved vascular surgery residency with passing of ABS vascular certification within 70 years, and that the training includes the open surgical and endovascular experience, passing the RPVI examination, and gaining knowledge of medical management of vascular patients. Recommendations for renewal of privileges for vascular surgeons include passage of recertifying examination in vascular surgery within 10 years, completion of the MOC, participation in regional or local registries like the SVS-VQI, and passing the RPVI examination or appropriate CME in the non-invasive vascular laboratory. Renewal of existing vascular privileges for non-vascular surgeons include the same requirement, except that the surgeon must pass the recertification examination in her or his specialty within 10 years. The document concludes that the SVS, in agreement with the Joint Commission standards, believes that the decision to grant or to deny hospital privileges in vascular surgery to new applicants or to those with established practices, irrespective of specialty, should be based on objective, evidence-based process. The next paper I would like to introduce to you is our CME paper for May. It is entitled Outcomes of Thoracic Endovascular Aortic Repair for Chronic Aortic Dissections, written by Dr. Alan Conway and colleagues from the Lenox Hill Hospital in New York. Out of 4,713 TVAR patients enrolled in the VQI registry, only 125 were performed for chronic Type B aortic dissections. Technical success was 98%. In-hospital mortality was low, it was 2.4%, stroke rate was 0.8%, and spinal cord injury occurred in 2.4%. There was an unusually low rate of endoleak during a median follow-up of 8 months, and only one patient reportedly had a type 1B endoleak, and sac shrinkage occurred in 28%. It was not related to the extent of wall coverage by the stent graft. The authors concluded that TEVAR for chronic tie-based dissections is safe with low rates of complications, endoleaks, and reinterventions at a median of 8 months after the intervention. The next paper reports on preliminary results of endovascular aneurysm sealing from multicenter Italian research on Nellix Endoprosthesis, the IRENE study written by Dr. Bruno Cosetti and colleagues. Now, in this large Italian retrospective study, there was no mortality within 30 days, and endovascular aneurysm sealing using the Nellix device in 335 patients resulted in 1.4% type 1A, and 0.07% type B, and 1.1% type 2 endoleaks at 1 year, with freedom from aneurysm-related reintervention in 94.7%. 4 of the 12 reinterventions were surgical conversions due to aortoduodenal fistula, endograft infection, and in patients for type 1 endoleaks in 2 patients. Through 1 year, 19 deaths were reported, including 2 that were procedure-related. The final paper I would like to bring to your attention is entitled Grip Strength Measurements for Frailty Assessment in Patients with Vascular Disease and Associations with Comorbidity, Cardiac Risk, and Sarcopenia, written by Dr. Thomas Reeve and colleagues from Winston-Salem, North Carolina, and Ann Arbor, Michigan. In this prospective cross-sectional cohort study, the authors used a calibrated hydraulic hand dynamometer to measure grip strength in 311 patients with vascular disease. Association between grip strength, Charlson Comorbidity Index, Revised Cardiac Index, and sarcopenia based on total psoas area for patients with cross-sectional abdominal imaging were evaluated using linear or logistic regression. There was a significant association between psoas area and grip strength, and this association remained highly significant in an adjusted multivariable model. Dominant hand grip strength identified frailty in 27.7% of the 311 patients, and there was significant association not only between frailty but also between comorbidity and cardiovascular risk. So the result of this study suggested that frailty is highly prevalent among patients with vascular disease, and that grip strength measurement is potentially useful as a screening tool in this population. Now, these were just a few of the many excellent papers from the May issue of the JVS. Feel free to download each of these articles free of charge. To access them, please visit us on www.jvssearch.org. Enjoy reading all JVS journals and let us know if you have any comments or suggestions. And see you next time for the highlights of the June issue of the Journal of Vascular Surgery.